It is my delight to present for you some of the most current information on the novel coronavirus outbreak called COVID-19 or SARS-2. I'm Dr. Michael LeVasseur, and today is February 29th, 2020. That date is important given that this outbreak is playing out rapidly across the world stage. I must admit that with great deference to the severity of this epidemic, it has been fascinating to watch this unfold. Just a little bit about me. I'm a visiting assistant professor of epidemiology and biostatistics at the Dornsife School of Public Health at Drexel University here in Philadelphia. My primary research interests are in infectious disease epidemiology, gender and sexual minority health disparities, and data science. While my particular research interests revolve around sexually transmitted infections, I do have a strong background in virology from my undergraduate training, and it's been an absolute treat to dust off the old lab coat and think about molecular biology again. It's also worth mentioning that I'm a PhD and not an MD, so if you have specific questions, I encourage you to talk to your doctor. Before we begin, I want to mention that there are some things in this presentation that are highly technical and others that might sound frightening. It is my strong belief that accurate information is a panacea against fear and ignorance, and I will do my best to explain the more complex concepts to a degree that helps you understand what is happening, and I hope that we have some fun along the way. I'll be covering a wide range of topics in this presentation, but I will hyperlink to each section separately for ease of navigation. We begin by exploring some of the biological aspects of COVID-19 and then discuss its origins. Next, I'll describe the transmission dynamics, basic epidemiologic features, and prevention techniques for this epidemic. Finally, I'll give a brief epidemiologic forecast and respond to some more specific questions raised by friends, colleagues, and students. Now, let's get started with our discussion of the biological features of COVID-19. On the right, there's a depiction of a coronavirus. You can see the spiky protrusions on its surface, which look like the corona of the sun. Coronaviruses are a family of enveloped, positive-sense, single-stranded RNA viruses. These classifications may not mean much to you, but they actually reveal quite a bit about the virus's origins, transmission, and replication. In this section, we'll explore some of the basic aspects of coronaviruses, their symptoms, treatment, and broadly discuss the key epidemiological features of this. There are four subspecies of coronaviruses. Alpha and beta coronaviruses primarily infect mammals, while gamma and delta coronaviruses mostly infect birds. There are 7 known coronaviruses that infect humans, 4 of which circulate regularly during cold and flu season and cause between 15 and 29% of what we call the common cold. The 3 coronaviruses of public health concern are SARS, MERS, and SARS-2, also called COVID-19. On the left, you'll find the 4 coronaviruses that we associate with the common cold. 229E and OC43 all have symptoms you'd expect, including general tiredness, headache, runny nose, sore throat, fever, and cough. NL63 and HKU1 are a little more severe, with both NL63 and HKU1 having more severe respiratory involvement. That said, the symptoms of these coronaviruses are much milder than what we've seen with SARS and MERS. You may notice that both of these viruses can cause gastrointestinal symptoms. Coronaviruses in animals can cause gastrointestinal rather than respiratory disease. A paper published yesterday in the New England Journal of Medicine has shown that COVID-19 is present in some anal swabs and fecal samples. Most cases of COVID-19 will be mild and more like a cold. For these cases, bed rest and over-the-counter medications you'd use to treat a cold are perfectly fine. Keep in mind that a mild case is a feature of your body's response to the virus and not some feature of the virus itself. Therefore, you should still isolate yourself and especially avoid those at higher risk of severe disease, such as those older than 65 or individuals who are immunocompromised. For more severe cases, acute respiratory distress syndrome, ARDS, has developed in 17 to 29%, and a large proportion of individuals with COVID-19 infection and pneumonia have required respiratory support, including the less invasive high-flow oxygen therapy or non-invasive ventilation. But many required mechanical ventilation, and some extreme cases required advanced organ support and even extracorporeal membrane oxygenation. So how do coronaviruses infect humans? Well, here's a little map of how the virus gets into the cell, replicates, and comes back out to infect more cells. First, the virus attaches the spike protein to cellular receptor. For SARS and COVID-19, this happens to be the ACE2 receptor. And then the virus enters the cell, although the exact mechanism is unclear. And then the virus begins transcribing viral RNA directly in the cytoplasm. Proteins are synthesized in the endoplasmic reticulum, and new variants are assembled in the Golgi apparatus, which then bud from the host cell and go on to infect other cells. There's some research underway exploring some potential treatments for COVID infection. Remdesivir is a nucleoside analog drug that works by halting viral replication and is similar in action to drugs you may be familiar with, such as Truvada and Descovy. It is shown to work very well in laboratory settings with other single-stranded RNA viruses, including Ebola and Marburg, SARS, and MERS. It should be noted that it was not terribly effective against Ebola, but researchers are hopeful that the strong effect that they've seen against SARS and MERS will bode well for human trials, which are underway right now. Many of you may also be wondering about a SARS vaccine. The development of a vaccine is predicated on a virus's immunogenicity, its ability to generate a sustained immune response. There's been some research into this that has shown that those with a severe SARS infection, antibody production peaks at 4 months and wanes thereafter. Among a fairly small sample of SARS survivors, 89% had an immune response after 2 years, and only 9% had a response after 6 years. Immunogenicity appears to be dependent on the severity of the illness itself. The immune response to COVID-19 is currently unknown, but it is likely that it would be similar to SARS, meaning two things. One, lifelong immunity post-infection is unlikely, and two, vaccine development is unlikely. Most viruses have evolved mechanisms to avoid the immune system. Coronaviruses are pretty expert at this, and it is likely that their efforts directly lead to severe infection. In this section, I will be throwing around some terms that you probably haven't thought about since high school biology class, and that's okay. I will try to explain them as quickly as possible. Coronaviruses encode for a number of proteins that are involved in their reproduction, assembly, and infectivity. These are termed the structural proteins. But they also encode for 16 non-structural proteins, or NSPs, that are involved in changing cellular processes. NSP1, for example, inhibits the assembly of a protein complex that turns a cell's antivirus software on and turns off a cell's ability to make its own proteins. NSP3 interferes with the ability of cellular protein called IRF3 to enter the nucleus and give work orders, called transcription factors, demanding production of interferon, which is an incredibly important chemical in dictating an immune response. NSP16 has the ability of masking viral RNA to look like human RNA so that the body doesn't recognize the viral RNA to destroy it. And N protein can inhibit NF-kappa B and PKR function. NF-kappa B is a master regulator of immune function, and protein kinase R inhibits the synthesis of viral RNA. Look, coronaviruses didn't invent immune evasion. In fact, most viruses have some capability of hiding out, and most of the time our immune system wins out in the long run. Viruses don't want to kill us. They just want to borrow our cells for a bit to make more copies of themselves so that they can infect other people. Coronaviruses have another trick up their sleeve, and it happens to be my favorite trick, the glycan shield. This is a glycoprotein complex that surrounds viral entry proteins, the S protein spike for coronavirus. In order for antibodies to work, they need to bind to small pieces of antigens called epitopes. Most antibodies are fairly specific to what they bind to and require a specific shape to do their work. The glycan shield covers the viral receptor and prevents antibodies from attaching to them without affecting the protein's ability to bind to the cellular receptor. The glycan shield has been one of the primary reasons that we don't have a vaccine against HIV, and it plays an important starring role in the story of the failure of AIDS-Vax, which was the first potential vaccine against HIV to reach clinical trials. Because the primary cause of severe illness in COVID-19 infection is acute respiratory syndrome, I thought I'd spend some time explaining what we know about ARDS. ARDS is a type of respiratory failure characterized by a rapid onset of widespread inflammation of the lungs. Prognosis is poor with mortality around 40%, and there's poor quality of life among those who do survive. While it is unclear in the context of COVID-19, bacterial pneumonia is present in 60% of generalized ARDS patients. It isn't clear whether or not vaccination against pneumonia reduces ARDS, but it certainly doesn't hurt, which is why I recommend that people get the pneumonia vaccine. ARDS development is poorly understood in general, let alone in the context of COVID-19. But there are some features of coronavirus immune evasion that may help to explain this. First, there's very rapid viral replication once an infection is established, which causes cells to counter with rapid production of pro-inflammatory cytokines and chemokines, which leads to infiltration of the inflammatory cells into the lungs. There also appears to be a difference in ARDS development based on whether type 1 pneumocytes alone or both type 1 and type 2 pneumocytes are infected. Third, coronaviruses inhibit the production and activity of interferon, which inhibits the activity of monocytes and macrophages, the immune cells that are recruited into the lungs in step 1. All of this leads to the accumulation of monocytes, macrophages, and neutrophils that can then cause the immune system to go haywire. These cells produce chemicals that destroy infected cells, and if we can't turn them off, can destroy large amounts of tissue. I recognize that all of that might sound scary, so let's zoom out from the cellular level to the population level. In infectious disease epidemiology, we discuss 3 factors that contribute to the burden of disease. Pathogenicity refers to the capability of an infectious agent in causing disease. Many infections are not very pathogenic at all. Herpes, for example, does not often produce symptoms in those who are infected. With COVID-19, only 14% of infected individuals appear to have severe disease. The rest either have a mild course or no symptoms whatsoever. Virulence refers to the severity of the disease that does appear. When herpes does cause symptoms, they aren't terribly virulent, whereas the disease caused by Ebola infection is incredibly virulent. Right now, COVID-19 has a 2.3% case fatality rate. This is much lower than the case fatality rate of SARS, which was around 9%, or MERS, which was 36%. You may ask me, okay, well, how serious is this then? And my response will be somewhere between a 3 and a 4 on a scale of a 1 to 10. The third characteristic is that of infectivity, or the likelihood of infection. By this point, we've all become at least a little familiar with the basic reproductive rate, R0. R0 is based on a fairly simple equation where R0 equals the number of susceptible contacts per day times the per contact probability of infection times the duration of infectiousness. If we can reduce any of these factors to 0, we can halt transmission of the virus. Since we do not know the per contact probability of infection nor the duration of infectiousness, R0 can only really be hypothesized at this point based on mathematical modeling and simulation studies. R0 is a very useful number for public health officials, but it doesn't mean much for the general population, largely because R0 is most useful in determining the proportion of individuals needed to be immunized in order to halt transmission, also known as the herd immunity proportion. One of the primary reasons that R0 is fairly useless as a statistic is due to that C parameter. Some individuals have many more contacts than others based on their personality or popularity or job. The distribution of contacts per day is highly skewed, and therefore an average is an inappropriate measure. To say that the average person will go on to infect between 1.4 and 2.5 people is disingenuous characteristic of transmission. Most people won't infect anyone else, but a few people, called super spreaders, will infect a large number of people. We've seen this with other coronaviruses like SARS and MERS, and we've already seen this with COVID-19. Next, we're going to discuss the origins of COVID-19, including an explanation of how we know this from science and why anyone who claims that it is a man-made infection is a complete idiot. The first clear evidence that we have for the origins of SARS-2, here called human 2019 nCoV. Isolates of the virus were taken very early on in the epidemic, and their genetic sequences were compared to other coronaviruses that we had sequences of. In panel A, we see that the new virus is very closely related to 2 bat SARS-like coronaviruses and share a common ancestor. It should be noted that both of these samples came from a specific type of bat called a horseshoe bat. When early samples of SARS-2 were examined by researchers, they noticed that they were all very similar to one another. Viruses mutate at very predictable rates, and we can use this information to determine when the virus jumped into humans. Since all of these samples were remarkably similar to one another, it became clear that this virus entered human populations very recently. We can also use the difference between the sequences to approximate that this interspecies jump likely occurred between late October and early November of 2019. It is excellent news that we identified this virus so quickly, as it allowed us to act quite rapidly. It's a shame that that response didn't have a huge effect, but it still gives me a lot of hope for future epidemics that we can identify them this quickly. We can look at similarities between the genetics of the new virus with other viruses. In this graph, we see the sequence similarity between SARS-2 and 3 other coronaviruses. The 2 bat coronaviruses we identified as being related, and the 2003 SARS virus. The purple and blue lines show very clear similarity, with the exception of the S protein. And this isn't surprising considering that the S protein is the one responsible for infecting human cells. What is interesting is that it isn't as closely related to the 2003 SARS virus, the one in red. We could also compare the amino acid composition of the structural and non-structural proteins of SARS-2 compared to other coronaviruses. It isn't surprising given the genetic similarities that the amino acid similarities are also high. Many of you have asked me whether or not this is the result of bioweapons research or some other nonsense. Quite frankly, no. There are a couple of easy logical explanations for why this is such a silly conspiracy theory. First, COVID-19 has a 2.3% case fatality rate and was identified very early on in the epidemic. If you're going to make a bioweapon, you want it to be a lot more silent at first and much more deadly. We also know the sequence homology of the virus and determined its closest ancestors very early on. Occam's razor says that the simplest explanation is often the correct one. Putting this all together, COVID-19 is a SARS-like virus and can be classified as SARS-2. It is closer phylogenetically to bat SARS coronavirus than it is to the human SARS virus from the 2003 epidemic. Its similarity with these 2 bat coronaviruses implies a direct common ancestor. Since the early cases were nearly identical in genetic sequence with about 99% similarity, this virus recently emerged in humans sometime between late October and mid-November of 2019. And finally, anyone claiming that this is a bioweapon has clearly never studied virology, worked in a research lab, or even read a scientific paper. You are encouraged to publicly shun people spreading idiotic conspiracy theories since they are harming the public health response. This is yelling fire in a crowded movie theater.
Shame, shame, shame.
Next, we can move on to the transmission dynamics of COVID-19. Do you know how many high-speed photos of sneezes there are in Google Images? A lot. I'm not entirely sure why this excites me, but it certainly does. When we think of transmission of infectious diseases, we most often think of 4 modes of transmission. Direct contact, where an infected individual passes the infection on directly through kissing or shaking hands or sexual contact. Indirect contact, where an uninfected individual touches an object that is contaminated and becomes infected. Airborne transmission, where very small particulates spread through the air, and droplet transmission, where larger droplets from coughing or sneezing can cause an individual to be infected. Droplet transmission can result in airborne transmission if in close contact within 3 to 6 feet. But more often is the result of direct contact, sneezing or coughing into your hand instead of into your elbow, or indirect contact where droplets settle on surfaces. With respect to coronaviruses, the primary methods of transmission are through direct or indirect contact. The length that an infectious particle, bacteria or virus, can survive on a surface varies based on its composition, room temperature, exposure to ultraviolet light, and relative humidity. It is not clear how long coronaviruses are viable on surfaces, but in a few studies looking for the presence of SARS RNA in an airport in Saudi Arabia or in SARS units in Toronto, Bangkok, and Taipei following the SARS epidemic, all found evidence of the virus on surfaces after patients left. How long? That's not clear, and I'm sure work will be done exploring this in more detail. Direct contact is still the most likely source and is why I'm recommending social distance measures. Droplets themselves can spread 3 to 6 feet from where they were expelled. With respect to aerosols, these are also temperature and relative humidity dependent. They are also dependent on the location of the infection in the lungs, with lower respiratory infections being more likely to result in aerosolized transmission. Some studies of SARS have found aerosolized virus, but that these do not last very long in the environment. COVID-19 has seen exponential transmission in numerous countries. We'll explore some of the epidemiology in this section, but it is important to understand that this is a rapidly evolving epidemic, and I expect that we'll have far more robust measures in the next 5 to 10 days as the outlook in Italy and Iran become clearer. Here I've provided a table of the 7 human coronaviruses we've discussed. The non-lethal viruses have a prevalence between 2.2 and 1, and incubation periods between 2 and 5 days. There's also a tremendous seasonality associated with these viruses, with peak transmission occurring in January. Each cold and flu season seems to have different prevalence of these viruses. SARS itself disappeared after 2003 and is no longer circulating in the general population. But when it was around, it had a 9% case fatality rate with median time to death of 23 days post-infection and an incubation period between 2 and 11 days. MERS-CoV has a prevalence around 0.15%, but is largely contained to specific regions with little human-human transmission. It does have a 36% case fatality rate with a median time to death of 14 days and an incubation period of 2 to 13 days. Prevalence of COVID-19 is unknown at the moment since this is still an evolving epidemic. However, we have seen a 2.3% case fatality rate, a median time to death of 14 days, and an incubation period between 6 and 10 days. I should point out that this case fatality rate is very likely an overestimation, since the earliest cases were very severe. I suspect that the case fatality rate from Italy will be much lower than 2.3%. That's largely based on enhanced screening and better understanding of the disease course. Demographics of the Chinese epidemic have shown a much higher case fatality rate among those 80 years of age and older, and also among men. There was also a high prevalence of comorbid diseases among those who died, including cardiovascular disease, diabetes, and COPD. Interestingly, among 0 to 9-year-olds, there were no deaths. Since ARDS is a common complication in serious cases of COVID-19, I thought I'd mention some of the demographic characteristics of this as well. Keep in mind that these numbers are with respect to ARDS in general and not specifically among those with COVID-19 infection. Recent surgeries, obesity, and COPD have all been linked to a higher risk of developing ARDS, as has chronic alcohol abuse, cigarette smoking, ozone exposure from environmental pollution, and, interestingly, vitamin D deficiency. As many as 96% of ARDS patients have been seen to have vitamin D deficiency. This may just be because vitamin D deficiency is common among adults, but I think that this is an area where more work can be done. Here we can see some of the basic epidemiologic curves and maps of the spread of COVID-19 throughout Europe. The initial increase in cases in Italy, shown here in yellow, is likely a screening bias, but we have seen exponential growth in infections with this disease. Epidemiologic maps can tell us quite a bit about what to expect. Europe and the rest of the world is still in the early days of this epidemic, and it will continue to spread. Next, I want to talk about prevention. Considering the lack of treatment options, the rising spread of the virus globally, and minimal prospects of vaccine development, preventing the disease from spreading is our best hope at slowing its progression. I know you don't want to hear a whole lecture on hand washing, so instead I'm going to give you a lecture about my favorite history in all of public health history, Ignaz Semmelweis. Semmelweis was an Austrian physician working in Vienna General Hospital. He was appointed to an equivalent position of chief resident of obstetrics in 1847. Since Vienna General was a teaching hospital, patients were given free or reduced cost care in exchange for allowing medical students to train. 2 OB clinics were available to women, which held admissions on alternating days. Problematically, many women died during childbirth at this time from a condition called childbed fever or puerperal fever. With the 2 available clinics, one had a much higher maternal mortality rate than the other. Women in the community were aware of this. Sometimes they preferred giving birth in the street rather than be admitted to Clinic 1. Semmelweis later reflected on this by saying, "To me, it appeared logical that patients who experienced street births would become ill at least as frequently as those who delivered in the clinic. What protected those who delivered outside the clinic from these destructive, unknown endemic forces?" What indeed? Both clinics had similar protocols and only really differed in staffing. Clinic 1 was staffed by medical students, while Clinic 2 was staffed by midwives. Semmelweis pondered this and considered a number of options, including overcrowding or climate differences, but none of these really explained it. Around this time, a colleague of his passed away after accidentally being poked by an instrument during an autopsy. This man's post-mortem examination revealed a similar pathology to that of the women dying in the clinic. This led to Semmelweis to the theory of cadaveric contamination, that some agent present in cadavers is causing the malady. Semmelweis implemented a protocol for medical students to wash their hands in a solution of chlorinated lime before delivering children. This policy was implemented in mid-May 1847. Mortality rates dropped from 18.4% in April to 2.2% in June. You see, the predominant theory of disease causation at this time was called miasma theory. It held that foul emanations were the cause of disease. It wasn't until the work of Louis Pasteur in 1870 and Robert Koch in 1880 that germ theory started taking over as the primary paradigm of disease causation. As such, Semmelweis's hypothesis was largely ignored and he was ridiculed by the medical community. Due to mounting political pressure from the Hungarian uprising, Semmelweis was dismissed from the hospital and forced to move to Budapest. I like to imagine that Semmelweis often yelled, "Wash your damn hands!" Of course, probably would have spoken in German, so it would have sounded more like, "Wasche dein verdammten Hände!" Anyway, he started getting drunk and writing angry letters to colleagues, often accusing them of being irresponsible murderers. Sounds a lot like drunk texting, which is fun. His colleagues did not love this, and neither did his wife. But he started drinking and became forgetful and would turn every conversation into a conversation about childbed fever, as though he just started the paleo diet with his CrossFit buddies. By 1865, he was institutionalized. He died 14 days later as a result of septic shock, likely because he was beaten by the guards. He would never know the true impact that he made. So if you're not going to wash your hands for me, then wasche dein verdammten Hände for Semmelweis. You may think that hand washing is easy, but as it turns out, effective hand washing can be a bit more involved. There are a number of methods that have been developed for effective hand washing. The CDC and World Health Organization have different methods, and I'll link to short videos that detail these, as PowerPoint does not allow me to record videos. On average, we touch our faces 3.6 times per hour. Most often, we become infected with respiratory and gastrointestinal diseases from our hands. You touch a doorknob that an ill person transferred their germs to, then you scratch your nose or bite your nails or rub your eyes, and then poof, you're exposed. The key here is to limit the amount of virus that you are exposed to, and we can do this in a few ways. First, reduce the number of times that you touch your face. My best advice is to be mindful about this, as it's not an easy task to accomplish, but you will get used to it. Second, wash your hands often. Use soap and water and make sure you get both sides of your hands between your fingers, under your nails, and don't forget about your thumbs. One verse of Twinkle Twinkle Little Star is all you really need, but any song will do. Why not sing it out loud? Maybe your fellow hand washers will join in and you'll become a hit a cappella bathroom sensation. When I say often, I mean after using the restroom, before preparing food, before eating food, and after being in a public space. If you find yourself in a situation where you cannot wash your hands with soap and water, you can use a hand sanitizer with at least 60% alcohol content, but use the same hand washing methods described before and make sure you get it under and around your nails. Soap and water is best, hand sanitizer is second best. Third, we want to limit close contact. Think about waving instead of shaking hands. We can also tap elbows if you want to maintain some level of physical intimacy without sacrificing hand hygiene. Think about how many people you touch in a day. Now think about trying to reduce that number. And don't be offended if someone doesn't want to touch you. Right now, we need to suspend some of the rules of etiquette just a little bit. Keep in mind that your personal effects are also harbingers of germs. Your phone, keys, smartwatch, and other devices that you touch regularly can also serve as a source of contamination. Imagine how dirty your hands are when you use your phone. What happens when you wash your hands diligently and then pick up your phone to tweet to Justin Bieber or whoever the kids think is cool these days? Is it me? Am I cool? Oh wait, I don't care. Unless being cool means that you want to be more like me, and that gets you to wash your hands and get your flu shot every year. Finally, it's worth reminding everyone to cough and sneeze into your elbow instead of your hands or into the open air. This also helps prevent direct and indirect transmission. But Mike, then my shirt will have germs on it. Yeah, sure, but who's touching your shirt other than you? The other day I stopped into the CVS for a prescription and decided to stock up on some items to help me with my own hand hygiene. I purchased some lovely cucumber melon hand soap, hand sanitizer that is at least 60% alcohol in two sizes, a travel size and one to refill my travel size bottle. I also picked up some extra rubbing alcohol just in case. And finally, I purchased alcohol prep pads that I can use to disinfect my phone and watch when I'm out at the gym or taking the subway. I wasn't able to find any alcohol-based products that weren't at least 60% alcohol, but just make sure that when you buy your supplies that they are at least 60%. They'll say it somewhere on the bottle or on the package. I carry the small bottle of hand sanitizer and a couple alcohol prep pads with me in my bag or in my jacket pocket. I'm also not afraid to share, so if you want to wipe down your phone and you see me out in public, ask for one, I've got them. I know I didn't mention face masks. I think these are excellent personal protective equipment for individuals at high risk for infection. This includes healthcare workers and, during this primary season, poll workers. They're recommended for those who are sick so they don't spread the disease. But imagine sneezing into one and walking around all day with that. Gross. No thank you, a pass. Healthcare workers are highly trained in putting on and taking off personal protective equipment, including face masks. It is more likely that you'll accidentally infect yourself taking off a mask than it is that you'll prevent being infected in the first place. The best thing you can do is, say it with me, all together, wash your hands. Okay, I sang it that time. Next, we're going to take a look at this epidemic and try to predict the future. First, there are some important terms to understand with respect to any epidemic. Sustained transmission, or community spread, occurs when an infection spreads beyond clusters of patients. If you recall our conversation about the R0 value, you'll remember that this is based on the product of the number of susceptible contacts per day, the per contact probability of infection, and the duration of infectiousness. An epidemic is defined as any disease with an R0 greater than 1. An endemic disease is when the R0 is at or near 1, which implies that any infected person is unlikely to pass it on to more than one person. And a disease headed towards elimination will have an R0 value below 1. Two other terms to keep in mind are mortality rate and case fatality rate. These terms are often incorrectly used interchangeably. Both statistics use the number of people who have died as a numerator, but the denominators differ. For a mortality rate, the total population at risk serves as the denominator, while a case fatality rate uses the total number of cases. This entire presentation we've discussed the case fatality rates. Finally, a disease is considered pandemic when there is community-level human-to-human transmission in at least 2 countries in different World Health Organization areas. Please do not call this a global pandemic because there's only one kind of pandemic and it's global. In 2009, the World Health Organization set up guidelines for pandemic influenza preparedness and response. In it, they outlined the 6 phases of a pandemic. The first phase involves viruses circulating among animals that have not yet caused human infection. In the second phase, an infection has caused at least one infection in humans. In phase 3, small clusters of cases in humans, but they have not resulted in direct human-to-human transmission sufficient to sustain community-level outbreaks. During phase 4, there's been verified human-to-human transmission, and it's shown the ability to cause sustained community-level transmission. In a phase 5 epidemic, human-to-human spread exists in at least 2 countries within one World Health Organization region. And finally, we've reached the pandemic phase 6, where community-level outbreaks exist in at least one other country in a different World Health Organization region. This indicates that a pandemic is currently occurring. The 6 World Health Organization regions are the WHO Africa region, the WHO region for the Americas, the Eastern Mediterranean region, the European region, the Southeast Asia region, and the Western Pacific region. Some of you have asked me what this infection looks like. Most cases, around 80%, are mild. Symptoms develop 4 to 10 days after exposure. I was unable to find any information on the length of illness, but among those who go to the hospital, the median hospital stay is 12 days long. Keep in mind that these people are more likely to have a more severe infection. Typical symptoms among those who have been seen at hospitals include fever, cough, sputum production, and fatigue. In an analysis comparing severe to non-severe hospital cases that was published in the New England Journal of Medicine yesterday, the median age of those with severe infection was higher than among those with non-severe cases. Severe cases were also more likely to be smokers. The incubation periods between these 2 groups were similar, but those who developed more severe cases were diagnosed with pneumonia later than those with less severe cases. I'm not entirely sure what this means clinically, but I am putting the information out there. Finally, many of you have asked me about the safety of your infant children. According to a paper published February 14th in JAMA, 9 infants were infected with COVID-19 and were hospitalized in China between December 2019 and February 6, 2020. None of these infant children died. Given the number of infections reported, the number of infected infants identified was small. This may be due to a lower risk of exposure or incomplete identification due to mild or asymptomatic disease, rather than resistance to infection. So, will we see an epidemic here in the United States? Will people die? I just got a news alert on my phone that a patient died of COVID-19 in Seattle. It is time to get serious about this. I'm honestly not sure what the response will be. It is likely that schools will be closed and that telecommuting will become an important aspect of life in the next few weeks. Yesterday, I spoke with a friend who lives in Milan to see what the situation was there. He told me that while there was an initial panic and run on the supermarkets, people have since calmed down a bit, and it seems like many people are just happy for the social disruption. Keep in mind, this isn't a snow day. Do your hand hygiene and good social distancing. Finally, I'm going to attempt to answer some specific questions posed to me by my friends, colleagues, and students. Many of you have wondered if the media is sensationalizing this. I think it's a little bit of column A and a little bit of column B. Yes, this is serious. How serious? Moderate. This isn't a Category 5 hurricane, but it also isn't a light breeze. This is more like a severe winter storm. Some people will die, but it's not the apocalypse. The reason that this virus is intriguing is mostly because it is a test of our global epidemic response. This isn't the first emergent infectious disease we've seen in our lifetimes, and it certainly isn't the last. I think that it's fantastic that we identified and classified this virus so rapidly, but that our quarantine measures failed is disheartening. I suspect that we'll be talking about this failed response quite a bit in preparation for the next one. There have been a lot of comparisons to the flu, and for good reason. First, the public has a fascination with pandemic influenza, and we've talked quite a bit about H5N1 bird flu, H1N1 swine flu, and the 1918 Spanish influenza. So a comparison to the flu is not surprising. There's also similarity in prevention measures, and I think a lot of comparisons to flu has to do with individual responses and trying to shame people into getting the flu shot. Oh, you're so worried about coronavirus, but the flu is right here and you didn't get your vaccine? And I think that's a valid response. Things I've outlined here aren't things to do in a response to a pandemic. They're things we need to do every day for the rest of our lives to prevent all sorts of diseases, including influenza and the common cold. A lot of you have asked me about the economic impact, and quite frankly, I'm not an economist. But lucky for you, my friend Kevin is a market analyst with some perspective on the matter. First, recession is a technical term defined by 2 consecutive quarters of economic contraction as measured by gross domestic product, not the stock exchange. The supply chain will be and has been affected, and that will continue to have an effect on manufacturing. This sell-off is about the uncertainty of the response more than it is about supply chain or trade changes. Will this cause a long-term global recession? Ask me in 10 years for a more clear answer. And you're right, coronavirus is not the only epidemic in the world right now. I'm hopeful that the work that's been done in handling the Ebola crisis has trained a lot of public health professionals on the ground throughout Africa, but there are limited resources globally to deal with epidemics, and we're going to have to invest more in pandemic preparedness because this isn't the first and it's not the last. Finally, one of my absolute favorite teachers from high school, Mary Lou Kugler, asked her freshman history students at Watertown High School in Connecticut for their questions about this outbreak. I've selected one from each of the students, but I hope that the rest of this presentation has been helpful in clarifying other questions raised. Jack asks, why does this disease affect some patients worse than others? Are certain people more prone to getting affected based off of genetics or other diseases? Jack, this isn't entirely clear at the moment. Most of the more severely ill have had comorbid conditions that render them more susceptible to lung injury, but not all of the severe cases are in older populations. While this is an interesting and pressing question that research has been looking into for several years, there are no clear answers. Emily asks, how can the virus originate from animals, but the CDC believes that pets can't transmit the disease? Not all diseases can infect all animals. Pigs commonly spread influenza to us because the receptors in our lungs, called hemagglutinin, is similar in structure to those of pigs. Can dogs or cats get this coronavirus? Probably not, but I am not an expert in the lung morphology of dogs and cats. Greg wants to know if it's possible that the coronavirus can evolve to become something more dangerous. This is an excellent question, and I'm so glad that someone asked me. It is highly unlikely that this will become more virulent. In fact, most diseases are much more virulent at the beginning of an epidemic and then become less virulent as time passes. This is because viruses will adapt to our immune system in bodies. At the end of the day, viruses just want to spread, and a dead body doesn't spread much virus. From an evolutionary perspective, natural selection will select viruses that are less severe. If the disease leads to a respiratory sickness that already exists, why isn't there any treatment? Amarta, researchers have been exploring ARDS for a number of years and still haven't quite identified the root cause. It is likely that a systemic issue involving a number of interdependent chemicals in cells being uncontrolled. Karina wants to know if overcrowded populations were a factor in spreading the coronavirus. The answer to that is yes. Globalization, deforestation, and overcrowding are the exact reasons why we have seen an increase in emerging infectious diseases over the past quarter century. This, coupled with global warming, has also caused major shifts in ecosystems that put us in more contact with infectious vectors like bats and mosquitoes. Jasmine wants to know, how is the education of young people affected by the coronavirus? In fact, a lot of schools in China, Japan, South Korea, and Italy have closed. I imagine we'll see something similar here. My friend in Milan is a high school math teacher, and he has been teaching students remotely online. For teachers or students who haven't done remote learning before, this requires a big shift in how teaching is done. I actually think that we'll see a lot of creativity in the world of education in the next coming couple of months as educators and learners alike adapt to new ways of learning. Ava wants to know, how is traveling being impacted by the coronavirus? There have been a lot of travel bans put into effect, and I imagine that as the epidemic continues its upward swing, we'll see more put into place. I've been advising against traveling in the past week, but this may change as the epidemic evolves. Ian wants to know if the death rates for the virus, which are around 4%, are good or bad compared to other outbreaks of viruses. Well, the case fatality rate most often cited is 2.3%, but as I mentioned during this presentation, it's a little bit of a moving target. The answer here is pretty nuanced. All things being equal, this is a mid-level death rate compared to other epidemics, but not all diseases are created equal. For example, Zika has a very low death rate, but can have a huge impact on infant development. Ebola has a very high mortality rate, but isn't as hard to contain as influenza. Sam wants to know if the virus could affect the Tokyo Olympics, and if so, can they be moved to a different country, or will it have to be delayed? I suspect that there will be some effect on the Tokyo Olympics, and I know the Olympic Committee has been discussing what to do. The Olympics are in the summer, and I suspect that we'll see the disease go quiet around mid-May globally based on the seasonal trends of other coronaviruses. But I also expect that we're going to be right back to where we are in October or November of this year. And the Olympics could be a really good source for any kind of virus to take hold and any kind of epidemic to come back together. So it's possible that these will be delayed. I doubt they'll be moved to another country, but that's really the IOC's determination. Burton wants to know if there are any ways to prevent or cure the coronavirus. Currently, there's no cure for coronavirus, although there are some medications being tested. The best way to prevent this infection is just to wash your hands. Finally, Aaron wants to know if it is likely that a cure will be found, and how close are we to finding the solution. I don't think we'll find a cure for this disease. I can't really think of any viruses that we've cured. We've developed vaccines that have led to the elimination of smallpox, but this isn't a cure. There's some treatments that are coming around that I think will probably have a significant effect on treatment and prevention of disease, but I don't know that there will be an actual cure. I don't think that there's a solution to COVID-19, but I also think that the general outlook will improve in the next year as the disease becomes less fatal. Thank you all so much for watching this, and especially for contributing your questions. If you have more, I'll do my best to respond. In the meantime, don't forget to wash your hands. My 60% alcohol solution, it's actually 65%. Wash my hands, even though I've been at home all day and haven't come in contact with anyone because I've been putting together this presentation for you. And that's about all it takes. Enjoy, be safe.